I don't forget. I've actually been pretty good this semester. I usually have 1 or 2 classes that I completely forget to record, but I've got 4 classes, so at least there's always a backup for y'all. And if you've noticed on my YouTube channel, I put every single class recording there. And the reason why I do that is because the way you lecture, I could change something I've said or expressed it a little differently. And sometimes that can help you. So there are 4 recordings for every week there. The only one that there's 1 to is the review sessions. Do you know my last review had 685 views? And most of y'all spent at least 30 minutes on the review. I mean, there's some places you fast forward, I would too. And I just think that's amazing. And what that makes me is happy. That means you are using it, you are studying it, and it just shows, you know, that you all want this bad. And if you want it bad, I'm going to help you get there. So this is chapter 48, 49, musculoskeletal, neuromuscular dysfunctions. We'll get into what all that means. I'm sorry if the posting about the Kaplan math was confusing to some of you. It is due this week by Sunday. And remember, it is written wrong in the syllabus. We changed it because it was wrong, and we changed it for the new name. Well, they changed the name again. So it is Kaplan Advanced Math Pediatrics A. So if you see something like that in your Kaplan, that is what it is.
I have a question.
Advanced math. Yes.
I have a question, Ms. Bogart.
Mm-hmm.
I did it when I was in farm by mistake because there was some math we have to do in farm.
Okay, it still has to be done again.
So when I do it, is it okay to just redo it?
Just redo it,
okay.
Or at least go back and remediate it. Okay. Because it's just new information. It's just, you know, a refresh. In fact, all these maths are refreshed.
If I can just redo it.
Yes,
because I don't think it let me redo. I don't know if it's gonna save the score if I redo it, or if it's just remediate each question if it's okay.
Just remediate the questions and I'll be okay with that. I can see the time there. And on these Kaplan, I have to go into every single one of these that you've done for every single student on all of your campuses. So I have to look. So screenshot, you know, you could put them there, but I won't look at them. I have to go right into Kaplan. It's what my dean requires of me to make sure that you did do that 1 or 2 minutes remediation. And I understand why the remediation needs to be done. It does reinforce what you know. And sometimes you go, oh, I didn't know that. And it helps you understand something a little better. So, you know, I get it. It is extra work, but it is useful in the end. We do have discussion question number 6 that is due. So remember by Wednesday night to get that done. And the practice exam, thank you, Megan. It is open and it's ready for y'all to do by Sunday. If you have not done your assignment, your pediatric assessment assignment, you need to get it done or you probably will fail the course unless you have a 90 something in the exam grades. It is 6% of your grade. It's huge. Now, what does it mean if you turn it in this week? It means you start out with a 90. But still, if you look at the grades, most people are getting 90s and 100s. If you've done what I've told you to do, you have your references, you haven't plagiarized, you know, make it interesting. I mean, I love reading some of these assessments. Some of these details are amazing. And it makes me sit here and I can visualize these children. So I appreciate that. And then these teachings really shows me that the student, the parent, or even some nurses can learn from these. There's some different syndromes that I've seen that I've really had fun. I haven't seen the syndrome in a while, so it's like refresh for me. So I'm learning again too. So thank you. So let's start out with our PowerPoint, and then we're going to go into the Cahoots. Today the Cahoots, I think is 40 or 41. So we'll go to there. Now, I do my review tomorrow night at 5:30. If you look at your calendars, I have all 3 professors who teach PED this semester You will see the reviews listed there, and you'll have your Zoom numbers right there. So go to your calendar, and it's the easiest way to get to a review session. Okay, but I'm doing it first. I'm doing it Tuesday. Now, why did I do it Tuesday? It's sort of early, right? Well, if you're going through the review, this week studying things, you don't understand something, I keep Fridays open for those who need it, or Thursday afternoons to try to help you, and Friday afternoons for that. In the morning I have meetings, but in the afternoons I'm available to go over anything you need. Because remember, this is your third exam, and then you're going to go into your HESI. And I know most of you are scared of your HESI. HESIs aren't easy. It's very, to understand a whole course of information is a lot, especially when you have 3 courses going on. So anyway, let's start. I do have, so far it's a 100-question Kahoot for the HESI. So you'll be getting that. And we all 3 do something a little different. And I think the combination of all of us really gives you a good, clear picture of what you need to know. And then don't forget, you have your book, your NCLEX book with all of the different subjects that you have. The pediatric section is excellent. And I've been told by students, those little pictures, those little diagrams is where a lot of answers were. So, I'm just feeding you the information, what I've heard. So a child who is immobilized. When you have a child who can't move, it's due to many different reasons. Adults get immobilized to different reasons, and so do children. Now, it could be because this child will never get out of bed. It could be something to do with bone brittling diseases, and we'll get into that. Degenerative disorders, it could be, rheumatoid arthritis, that they can't move, or it could be hemophilia, where all of the blood in the joints and now you're immobile. So it could be immobile, and into a wheelchair. So there's all different things that causes a child to be immobilized. And it doesn't matter if it's a child or adult, we need to take care of these children, keep their lungs open. We need to prevent all of these side effects. So the muscular system, we know if we're immobile too long, you can get joint atrophy, and we know that the muscles can get stiff and they lose their strength. So we need to build that back up afterwards. The bones can become demineralized. The cardiovascular system, think cardiorespiratory, both of them together. We know that the heart, doesn't beat as well because you're not increasing your heart rate at all. So you're going to get venous stasis, edema, and at that point you can also get, blood clots, and your lungs can become, congested. Now, what if you are that kid who's immobilized? Can you imagine not being able to move, to get out of bed, to be able to go to another room, that you're stuck in one position? Well, this is a very hard thing for children. They want to get up and get out, and they want to move. I mean, what do kids do? As Paw Patrol says, they say, go, go, go. And that's what they want. So we need to do things to help these children get up and do that go, go, go. We don't want them frustrated and helpless, and then we don't want them angry, because if they can't be out where the action is, they become angry, and then they become very aggressive, only because they just want attention and they don't know what they want, and it's hard to express it. So you'll see that, and then you'll see the opposite with the regression. So if your child's immobilized, that means they can't get up and get out of bed by themselves, and they need somebody to take full care of them. It could be that myelomeningocele, where they have paralysis of the lower extremities or weakness on lower extremities. They need bowel care, urinary care. They need to be picked up, getting out of bed, put in a wheelchair. They need help with those things. And this requires a whole family. And the whole family now, before they go anywhere, vacation, going out in the car, going shopping, anything, it's going to take that extra time to take care of them. And, it's frustrating for children and parents. So these children, do need sometimes counseling, and so do the parents. you know, we've made in where the hospital I used to work at, they're all different support groups. The one for the children, you know, with neurological injuries, cardiac, respiratory. They have these groups that they get together once a month and they talk about all their frustrations. And it really helps keep a parent saying, you know, I'm not alone. I have other people who are just like me. So traumatic injuries, we're talking about things that happen, chewing gum, walking, slipping and falling, or it could be out playing sports. It could be to the muscles, the ligaments, the tendons, contusions, bruising, you know, walking into, you know, the side of a table and getting bruises. I know the side of the counter, and I'm always getting a bruise, you know, in my ribs because I'm always bumping myself there. So bruising in itself is not a bad thing, but think about a really bigger bruise, you know, where let's say it's a crush type injury, something fell on you, caused bruising and swelling. The one thing we need to be concerned about with bruising is don't just think it's a little thing. Because remember, this is swelling, it's compressing a vessel. Therefore, is the blood getting down further? Do you have capillary refill in that arm, that leg, that finger? You know, do you have mobility or not? You know, is blood getting there? Because it can cause, you know, no blood, necrosis could happen to that area. Dislocation is when a bone comes out of a socket. I think the most common ones that we see is literally this thing called a nursemaid elbow in the younger children. They're the little kids, 2, 3, 4 years old. You're swinging them with their arms like this, and their ligaments are so soft and stretchable that the arm can pop out of joint. You will see the kid with the arm hanging down and they can't pick it up. And it's basically just a dislocation. So they bring him into the doctor or to the emergency room. And all they do is go click, click, and it's back into where it needs to be. And then we just put them in a sling. Downs children, have you ever seen a Downs child take their legs, put them behind their head, both of them at the same time? They are so flexible. But in doing that, because they're so flexible and these tendons are loose, they can pop their hip joints out. And getting it back in could be very hard. And we are concerned about, you know, blood supplies when those things happen. Sprains, I think I sprained myself, at least 100 times playing sports throughout, you know, middle school, high school, and college. And it is a stretching of the ligaments. And it causes damage to nerves, muscles, tendons, and it will swell, it'll be ectomonic, and it hurts. I think a sprain is worse than a break. A break, you can set it, put it in a cast, and it'll be okay. A sprain, today they are casting some of them to help keep it in position and prevent pain. But sprains actually take longer. And then with the sprain, we need to be concerned of blood flow, neurovascular signs, capillary refill. Is it okay? And a strain is when we do something to a muscle repeatedly and it could cause it to hurt. I know walking through one of the Dallas airports, I had to go from terminal A to terminal E, from A1 to E50, and there was all this walking. I had these shoes on that were clogs, and that walking caused like these shin splints, which is like a strain. Also, with children, you know, playing sports, getting up and going and overworking something can cause a strain. So what are we going to do for soft tissue injuries? Just think of the rice. So you have gotten a sprain. You immediately rest the area, ice it, and icing off and on. Just don't keep it on, because remember, you still need blood supply going there, and ice will constrict vessels. So 30 minutes on, 30 minutes off, 30 minutes on is a good thing. Putting a bandage on it to prevent it from swelling more and keeping it elevated to let that blood flow and try to take that swelling away. And either putting a splint on or a cast to keep it immobilized, you know, so it will heal the correct way. Now, there's all sorts of fractures in children. There's fractures, we'll go into the different types coming up. Now, when you see a child repeatedly coming in with fractures all over the place, make sure you investigate, which means you're going to ask the parents the assessment, what happened. And then when you could get this child alone, like usually I like to take them to the x-ray. And then they're in the x-ray room, right? The parents have left, I'm with the child, and I'm going to say, so tell me, did you cry when you hurt yourself? Something to open up the conversation and see if the stories are the same. Now, if it's an infant, you have to work really hard to fracture anything in an infant. Infants are literally the strongest human alive. We try to think they're these fragile infants, but they can tolerate more than any adult ever could. If they have fractures, we need to investigate. I have a story of a 3-month-old who came in to the emergency room with a mother holding it in the arms, and she was crying and concerned. Something about some discoloration behind the ear, and the kid was irritable. So it was a busy ER, but I said, no, bring the baby back. The mother's upset. Let me just check quickly. So the first thing I do is to assess the child, is to weigh the child, current weight. Put my hand underneath the skull and underneath the butt to lift it gently on the scale. When I touched the behind the ear, it was smushy. It should be hard, the scalp. I knew the kid had a fractured skull. Now, when that happened, I just did my assessment quickly. And I immediately told the attending something's wrong. So I actually, because I was so concerned and it was busy and I didn't want it to be, delayed, I took the child to x-ray myself. And the attending said, go ahead and do the x-ray of the skull. If you see anything, just go do a bodygram. And what it is it's a 3-month-old baby. It fits on a whole big x-ray plate. And we could take the whole body. We found a healing fractured humerus, old fractured ribs, it's a 3-month-old, and a fractured femur on this infant. So immediately we're concerned child abuse. So we called in DCF. This was a child who was a twin. We called the twin in. The twin had the same exact injuries. And they also had a 2.5, 3-year-old boy who also we called in. And the kid was walking around on a fractured femur, limping, and had old fractured all over the body, different stages of healing. So we admitted these children to keep them safe until we could determine if the home was safe for them. And what we found out after a lot of questioning, it was the mother had the children and the father lost his job. So she had these new twins and this 2-year-old. And the father had to stay home and take care of the children. The mother was working 3-4 jobs trying to keep the family going. And the father got frustrated giving them a bath. They were crying. So he picked them up and he hit them on the surround, the tile surround in the bathtub, and cracked the head to get them quiet. So the father was taken care of. Don't worry about that. And then the children were kept safe. Now, probably one of those hardest kids I've ever taken care of, because I wanted to scream and yell as soon as I saw this. Now, that's not our goal. What our goal is to keep the kids safe. So that's what I did. I reported it immediately. I followed it through, and DCF came. And then, of course, the police came. And actually, the lieutenant in charge of child abuse is one of my neighbors. So I was able to follow the story through. And yes, the father did go to jail. Now, fractures can be all over the place, but children fall, they put their arms out. So usually they're going to fracture their radial and their ulnar. And sometimes it's one, sometimes it's twice. If you look at that poor boy, he's done it with both arms. Remember those hoverboards that just came out a couple years back? It was the craze at Christmas time. I think in 2 weeks when they were on break, I saw 3 bilateral fractured wrists, and these children all had to have their casts put on. So there's all sorts of fractures, but basically it's simple, closed, whether it is fragmented and cracked all over, but it's closed, it's inside the skin. And the other one is what we called an open one. These are dangerous because the bone protrudes through the skin. This is now a worry for osteomyelitis and infection because the bone has been exposed, to the environment. This one will require IV antibiotics and a long term of it, along with putting a cast on and monitoring that, arm, that foot, whatever it is, to make sure that we're not getting any infections. Another type of fracture is something we call a growth plate fracture or injury. This is with children. Now, children grow. So we know their arms, their legs, everything grows. The growth plate is at that place where it will grow, but it's the weakest part of the bone. Now, when you fracture that growth plate, making sure that it is put together properly is imperative, because if not, you're going to grow a crooked leg, short leg, or arm or finger or anything, that was fractured. So they usually, and a lot of times it's the elbow. I've seen a lot of those growth plate injuries, and they're going to go to surgery. They're going to be admitted. They do an open reduction, internal fixation, plate, screws, and they keep it straight so that this child's, arms and legs will be all at the same length. Now, if you and me get a fracture, we could have a cast on for 4 months, easy. In an infant, it's 2 to 3 weeks. They heal so quickly. And then the younger children, it's usually 4 to 8 weeks. So it's 1 to 2 months, and usually those casts are off. They really heal very quickly. So that's, at least they don't have to be in casts forever. So what do? Get the child coming in complaining, fell off the handlebars, of the gym, in the park, and hit the elbow, and now the arm hurts and you can see swelling, let's say in the wrist, it's all swollen, and the kid's complaining of pain. So going to take an x-ray, and again, remember the history, so important. Some children don't want to tell you they hurt, but if it's a leg and they're limping, something's going on. Children think everything's going to be a needle and it's going to hurt them. So sometimes they're not going to tell you about it. So our goal is to reduce it, to immobilize it, to let it heal so that the function can be where it needs to be, and then you're going to prevent deformities. So the assessment of a fracture. Now, that arm that's black could have a cast on it and no one ever checked it. And then you could see, you can really get a black arm like that. I mean, that's the extreme of all of them, but it can, cause necrosis of the tissue underneath. So we need to look the pain, the point of tenderness. We need to know the color. If it's getting pale, there's no blood going. If it's in the hand or the toes, we know no blood flow is getting down there. No blood, necrosis of tissue. No pulses, again, no blood flow. Starting to get numb, again, no blood flow. And then if you can't move, if you can't wiggle your fingers or toes with a cast on, there's a problem. And then most of the time you feel pressure, swelling, it's pressure. Mom, it hurts, there's pressure in there. And they need to come in, and they need to sometimes get a new cast, or sometimes put a window in the cast. Now, when we put casts on children, we can have fun with it. They can have their sports colors, or they can have the color of the season. This girl likes watermelon colors, but if you look, her doll has it on too. And that's not uncommon for pediatrics to do, to take care of it. And it makes this whole process not as bad for a kid. Could be red and green for Christmas, could be red or pink for Valentine's Day, or, let's say Miami Heat, black and red ones I've seen. Whatever you want. In pediatrics, we have colors. Now in the adult world, you just have the white ones. So we're going to be teaching, how do you take care of a cast at home? Well, number one, do not get it wet, okay? There are many children in South Florida, get a cast on, forget, go run, jump in the pool. That cast needs to be changed because it's wet underneath and it could cause mold to grow underneath there and could cause infection. So really careful with casts, you know, nothing inside, no sticking pencils in there, no powder, you know, keep ice on it, keep elevated for the first 24 hours. And, you know, Tylenol is what they need for pain. Now, sometimes a cast can't be put on. Think about having a fractured femur. You know, your long bone in your upper leg is cracked. And, you know, they need to do surgery, put a rod through it to stabilize it, but it's not done right away. Now, if you look at the fracture site, there's little sharp edges. So if it's off to the side, what is it doing? It's there punching at nerves and muscles, and it's swelling and it hurts. So if you look at this beautiful picture, this is called a Buck's traction. And it's just like a little boot you put on and it pulls the leg, so it pulls the bone, so it's end to end. So it prevents that movement of those sharp edges causing pain to that child. And then we have weights that hang. And the big thing is make sure you keep those weights free hanging so that we know there's weight. Never take the weights off because you're going to make that bone go in different directions. And when a muscle contracts and spasms, it's going to be hard to get it back to where you want it. I mean, look at the thigh muscle. It's huge. You're going to move it. It's going to be hard. And, you know, this Buck's traction, you should be documenting once a shift, how many pounds of weight there. Again, with this, it's still like a cast. You're going to check all the P's. You're going to make sure that the toes are movable, that they're pink, you have pulses, etc. Very important. So the traction, as I said, it's there to prevent those muscle spasms and keep the leg straight, waiting for that time where they can do the surgery. It prevents those deformities and it prevents further injury. And I think, you know, beyond all of the good things of keeping the bone straight and it's good for deformities, etc., it stops the pain because it really hurts. Now, there's two pictures on the bottom, and the one is the tongs into the head. And this could be due to a cervical fracture, something in the neck, you know, and then we have the halo devices, you know, or we have things that go over arms or legs and internal, those are external devices that help keep those bones straight. And there's pins that go directly into the skin. And those pins, all we do is clean them and usually soap and water and then apply a little bit of antibiotic ointment. I mean, every physician's a little differently, but that's about all. So there's all sorts of traction. You know, as I said, there's those halo ones, there's the Buck's one, there's the Bryant Russells, you know, the cervical halos, you know, all different things depending on what a child's needs. You know, this little baby here could be in the traction due to dislocated hips, which can happen. As I said, there's another type of device. A lot of times we use it when it's a really bad fracture, multiple pieces. It can't go into a cast. We need to have things put a certain way. You've put, you know, screws on bones and plates, and we put this external device on, and that holds that leg straight. Sometimes we use it when children are small or have a shorter limb to make it bigger, because we'll separate the areas and then the bone will grow in between. Now, sometimes children are born without a limb. I had a friend who had a daughter who was born without a fibula. So she literally had a below the knee amputation because there was no way to fix that missing bone. And that little girl was born with it. She had a prosthesis. And when she met my children, she ran around up and down the stairs and was beating them with her prosthesis. It didn't matter to her at all. This is something that children can be born with. Now, if it is an amputation due to a medical problem, these are the ones that children will complain of, that phantom pain. And, getting them up and moving is the most important thing. Getting the prosthesis on, and getting them, self-care is all children want. They want a me, mine, mine, mine. Children love to, I want to win. They always are. Everything is this game and they want to win. As they get older, it's more of the organized sports, your little league, your soccer, football, and children love to play. And it is a good thing to do. But it does take a lot of physical demands, and there are a lot of chances for injury. So these children, should be checked by physicians, make sure that they're available to go, that their bodies can handle it. Special needs, diabetics, make sure they have snacks, they have water throughout the games, that they keep their blood sugars up, because sometimes that happens with the diabetics, and then making sure that they warm up and they stretch. And have the proper equipment on, playing soccer, do they have shin pads on? They're playing football, do they have their helmets? Do they have proper shoes? This is so important to eliminate or decrease the amount of injuries. Today children are just so trying to be the best at whatever. I mean, with the Olympics that just went through, I can't imagine how much time that they spent training for these for the Olympics. And there tends to be what we call this overuse. It's, if we keep using the same joints, and it's rubbing and rubbing, it can cause a lot of injuries, whether it's stress fractures, tendon stretching, or just the rubbing and stretching of bones. All of these things are overuse. Now, infants can be born with what we call developmental dysplasia of the hip. When you take your child, newborn, into the pediatrician, one of the first things they do is have them on their back, and will take their knees, pull them up, push them to the side, and listening for those clicking and looking to make sure, and turn them over, make sure that their buttocks are at the same level, and making sure that their hips work. Now, what you see when you have a problem with a hip, that instead of the joint right into the hip socket, it's higher up. So that leg is going to be shorter. Another thing is when you look at the gluteal fold, you look at the butt cheeks, one is higher than the other. So you have a leg shorter, you have this fold that's different, and then you're going to hear these clicks. So it's a positive Ortolani and a positive Barlow test that you will see with this. Now, what do we do to treat it? Well, remember I told you infants, they really heal quickly. So they will put them in something called a Pavlik harness. 23 hours a day. You take it off to bathe them and put it back on. At all times, it should be on. And it puts the hips up into the right position for the hips to go in and to heal properly. Now, sometimes children are older, and as we have something in the wrong position, the tendons tend to tighten to there. It's harder to fix. So it takes a little bit more effort. Sometimes they need to go in and cut those tendons and do a tenotomy to help loosen that tendon to get it back into where it needs to be. But mostly we can do this with early intervention. Sometimes I remember being a young kid, and I remember my girlfriend's younger sister was in this white cast with the bar. It was a spica cast. And looking back at it, she had a hip dislocation and she needed a spica cast. And that also can help. Sometimes they need that. Another thing that can happen is what we call clubfoot. Now, you don't need to know all the names and what goes which way or that way. It's just a club foot, okay? Inside, outside, turn, any way, it doesn't matter. So how do we treat these? Well, we do serial casting, which is a Ponseti method, okay? They take and put casts on and try to get the feet in the positions they need to be. And they change them every week, okay? So this needs a diligent mom, keep coming in, coming in. And as this child gets older, the child really needs to be followed up with orthopedics to make sure that these feet stay correct, that's the way that they are. So it's something that starts as a baby. We can get them back where they need to go with exercise, physical therapy after these castings. And then as growing up, they do need good follow-up with it. I've actually seen an infant about that age who had a cast on, and the mother comes in with the cast in one hand and the baby in the other and said, "We got it put on yesterday. I don't know, but she got out of it." And I was like, how did that infant, I mean, tiny infant, how did they get out of it? And they do. Now there's something called brittle bone disease. Has something to do with a lack of something in the bones, and it causes fragility and it cracks. You can touch the ribs together. If it's too strong, you can crack ribs just touching these children. They're very difficult to take care of because you don't want to hurt them. So these children can get very deformed because they are constantly breaking their bones. Think of an immobilized child. An OI child, or osteogenesis imperfecta child, would be one of those. We treat them by giving some IV biphosphonate therapy, calcium preparations, vitamin D, but they'll never cure the osteogenesis imperfecta. But we try to decrease the amount of fractures that occurred. And our goal with these children, as they're getting these fractures, is to make sure that they can be in a positional body. Their body can be placed in a wheelchair, so that they can get around. I know these children, one little boy, he used to almost run me over in his electric wheelchair, going to the cafeteria to pick up a snack, and as long as they can move their fingers, they can get around. They're alert. They are smart children. Their bodies are just, breaking all the time. Lave cath perth disease is an aseptic necrosis of the femoral head, which means it's not an infection. It's just the head of the femur starts to die off. And it has something to do with the circulation to the head. If they don't get circulation, it's going to have that head die, and child's going to need a complete femoral head replacement. Usually doesn't get there. Usually what we'll start to see is a young child. We're going to start to see them limping. We're going to see them stiff, and they're not going to be able, that range of motion is going to be decreased. And it's usually, you'll see it in the morning or after they've been sitting down a long time. What they do is they'll do an x-ray, and what you see is the femoral head, usually one side, sometimes twice bilateral, but usually one side, be all like fuzzy white. So these are pain. They're really painful. So we do this treatment by rest. No weight bearing on that leg at all, and NSAIDs. And with this just rest, no weight bearing, and NSAIDs usually will take care of it. Sometimes the pain hurts so much, they'll put them on that Buck's traction, right? Or they'll put it in Bryant's traction just to get it to pull so that it's, in a good position. And sometimes that helps too. Now we're going to go into curvatures of the spine. Kyphosis is basically what we call humpback. This is where we have the thoracic spine gets big, and it's a hunchback, and you're bent over. It could be due to many different things, but the posture, you'll see them bent over. Lordosis is the lumbar spine goes too far in, and you can see this picture here. It's like they're leaning backwards. It is so far there. Scoliosis. Scoliosis is the S-shaped curvature of the spine. It's sometimes you're born with it. Sometimes it develops over time as a child. And it literally can go curved and it continues to curve. Now, with scoliosis, we don't know really why, but we see it most pronounced when you see that pre-adolescent growth spurt. And it gets a lot more curved. And that's when usually they'll say, you know, this kid's got a S-shaped spine. This is scoliosis. We need to do some treatment on it. Now, the treatment for this could be as simple as just physical therapy and a brace. Now, the brace on these pre-adolescents, you know, at this age, body image, remember, now they have this brace underneath. So they have made braces cute, you know, different colors, or these children have learned, you know, to make their brace, you know, look, you know, like a styling thing instead of just this hard plastic thing to hold their spine straight. Now, this must be on 23 hours a day. You only take it off to shower, you know, personal grooming, and then you put it back on. Put a t-shirt underneath so you don't sweat, so it's not right to your chest. And with that, there's exercise. And the exercise is done to strengthen the back and the muscles so that we prevent the S going even more. Surgery is only recommended for a curve more than 40 degrees. Now, the 40 degrees, now, if you can think, when we were looking at that curve and it starts to curve, that everything is pushing on that lung on the right side. If you look at this radiograph here, it's pushing on the lung. If we let it keep going, it's going to really stop that lung from expanding. So it is important that we either do bracing or we do surgery. And what they do is something called Harrington rods. And they'll take and put 2 rods on the either side of the spine and try to get it as straight as they possibly can. Osteomyelitis is an infection of the bone. And it looks actually like arthritis or leukemia. It's pain, bruising, swelling, and then you're going to see leukocytosis or an elevated white count, fever. And what they'll do is they will do blood tests with a blood culture, making sure it's not systemic yet. X-rays just to see where this infection is, and they'll do some bone scans to figure it out. So what is our treatment for osteomyelitis? Well, this is vigorous antibiotics, IV antibiotics for 3 to 4 weeks, and sometimes could be 2 or 3 months, depending on the severity of it. These children are usually sent home with a PICC line and given IV antibiotics. Now, osteomyelitis is usually a staph infection. So they use some very heavy antibiotics like vancomycin, aminoglucosides. You know, in aminoglucosides, we really must be concerned with kidney function. So we have to really tell these parents to make sure that they go up for their follow-up, you know, labs to find out their peaks, their troughs, and to look at renal function. And even after they're done with doing this treatment, to make sure that they continue to monitor urinary output, because that can show if there's any sort of kidney damage. So osteo should be on complete bed rest. That limb should be elevated. If there's pain, you know, give what they need. And of course, that IV PICC line works well. And of course, nutrition. You know, protein and carbs are needed for this child so that we do give these bones what they need to feel better. And these children, a lot of them are kept home. So, you know, they're going to need a little bit of emotional support, school at home, etc. Now, here are some tumors coming up, and they are tumors, but they have to do with bones. Now, Ewingsarcoma is a neuroectodermal tumor, which it could be from a bone, femur, tibia, ulnar, but it could be that scapula back there. Do you see the picture of that that arm, that's a tumor growing out of the bone, you know, or it could be in the jawbone, and they have to, you know, go through the whole thing, radiation, chemo, if they can, to resect it. And again, we know with anything doing with cancer, as long as it has no metastasis, you have a better potential for cure. Rhabdomyosarcoma, we've mentioned this before, but it comes from some muscle. This little girl here is coming up out of her mucosa in the mouth. It could be the nose, it could be in the eyes, it could be in the ears, but again, it could be in the retroperitoneal, perineum, you know, so this is just something, again, we will treat this with chemo, radiation, and try to get the tumor out if we possibly can. And this one gets long-term chemo. JIA, JRA, you know, it's basically an autoimmune disease where the body fights its joints. Children who get this, we usually see it at 1 to 3 years old is when that peak is of diagnosing it. And usually we'll just see a kid limping in the morning. You know, in the morning, they, you know, are not moving as well as they should. And then what happens is you could get this uveitis, which is red eyes that can occur. And then of course, we let it go too long, we're going to see the joint swelling disfigurement. So the problem with JIA, JRA is that there's no definitive diagnostic testing. It took me 10 years to diagnose myself, you know, and I know a little bit about things that go on in the body. It's just my body was showing different things every time. But, you know, once we finally can get a diagnosis on this, we'll see SED rates elevated. We'll see the CRP, C-reactive proteins. Any of those inflammatory markers will be elevated on it. When you're not, when you're really in pain, you might see your white cells, your leukocytosis. You might see those elevated too. So there's no cure. But what the goal in JRA, JIA is to help, you know, with the pain, keep yourself mobile, preserve the function, and prevent deformities. So it is NSAIDs is the medication of choice for the pain. And then, you know, these slow-acting anti-rheumatic drugs, Humira, Enbrel, and infusions if it needs to be. Corticosteroids usually are given when you're having those flares, and methotrexate can be used too. So there's different things to use, and every child is different. The biggest thing is getting them moving, keeping them stretching, physical therapy, occupational therapy, keep the pain down, you know, and then it's using heat exercise or cold exercise, whatever helps the child, and making sure that, you know, if they're on medications, that the child maintains compliance, you know, and putting children with other children with JIA actually helps the child and the family. Lupus is the other disease that's autoimmune that attacks its own body. Any organ it attacks. So JIA is joints, and we're talking lupus, we're talking about organs. It starts girls, women, 10 to 19, African American, Asian, Hispanic, and there is familiar. So if mom has it, possible that, you know, the daughter will get it too. We don't know what causes these things. We do know that there are triggers that can start these flares, and they're painful. It could be, you know, the girls going through, you know, their period, hormone imbalances, could be some sort of immune disorder, exposure to drugs, could be medications they took that their body didn't like, infection, stress, chemicals, and this one, overexposure to sunlight. So these children really need to be prepared, you know, with sunscreens every day before they go out, especially if you live in South Florida, you know, the sun gets pretty strong. So you're going to see the little red butterfly rash on them. And you'll see the nausea, the vomiting, the diarrhea, the pain, the stiffness. It's like the arthritic pain also. They also get to the point where they could have these neuro symptoms, forgetfulness, seizures, paralysis, and then of course, pleurisy, pericarditis, and that's infecting the heart. And then it goes to the kidney. Could be protein starts to come out and renal failure due to the body attacking the kidneys. Our goal again is to minimize those exacerbations, to have the child understand things that does bother this disease and make it worse, so that we can, prevent, the organs from being attacked, and of course, taking medicines as they're supposed to, compliance. So Kristen's 10 years old, sustaining fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what? What is an epiphyseal plate? What did I say?
Is that the growth plate?
Gonna be B.
Yes, it is. Growth plate. The most concerning fracture of all, because we don't want an arm or a leg to be shorter or crooked than the other. Good. Now we're going to go into some neuromuscular or muscular type dysfunctions. When you think of neuromuscular, the first thing we think of cerebral palsy. And cerebral palsy is a permanent disorder which affects the movements and postures and limits activity of this child. It could have happened during the developing fetus or during birth, infant brain. It is the most common permanent disability in childhood. And many of these children can also have epilepsy with it, because remember, it's affecting the brain. Now, the prenatal brain abnormalities, what can happen to cause cerebral palsy? Well, it could be some abnormality in the brain. It's just not connected right. Could be some vascular occlusion, which means something's not getting oxygen. It could be some laminar degeneration. Low birth weight has a big thing to do with cerebral palsy. I've told you that premature children, their brains have very fragile vessels in it, and they could burst and cause little hemorrhages in there, which are causing areas that are not getting the nutrition, the blood, the oxygen they need. Hypoxic and anoxic episodes are huge for causing cerebral palsy in children. Let's say a child is being born and it gets stuck coming down the birth canal, and then you have to run quick, do a cesarean section, and there was, a couple minutes where that child didn't get oxygen. Those children are more susceptible to cerebral palsy. Now, some of them are not that easy to figure out. Sometimes it's those assessments, those developmental assessments that we talked about the first couple weeks of class. Knowing if they can't lift their head up and they can't turn over, something's wrong. Now, probably the most common of cerebral palsies that we think about is the spastic cerebral palsy. It is characterized by hypertonicity, poor posture, and difficulty maintaining balance. This is the child, like my special kid, where I used to do my clinicals, Jonathan. He would look at me and he would just smile, and he gets so tense, and he just wants to, you come here and hug me now. But you can see it. They don't have control of their muscles, and it gets tight, and they have to work with it. Can you imagine having your arms flexed tight all the time? This is what cerebral palsy children do. So we will, looking at cerebral palsy, making this diagnosis, we will be doing these examinations, history, looking at the brain, see if there was anything in there not formed correctly, and then metabolic and genetic testing also. So with cerebral palsy, there was hypoxic, anoxic episode. There was something that caused the brain not to get what it needed. So you will see gross motor and gross fine motor delays. I mean, they will be in delay. Their motor functions are not going to be able to do these little fine little things with their hands. Their muscles usually are tight and spasm, and they can't move them like the way that they wish they could. So they're going to have abnormal postures. Their reflexes aren't going to be normal. You know, these children, many of them end up, you know, in wheelchairs or, you know, in bed. I mean, if they can get up and out of bed in a wheelchair, it's the best thing. Now, many of these children are more alert than they can express. A lot of them are nonverbal, which means they can't talk to you, but you can figure out what they want by just their eyes or their expressions. I can't imagine not being able to communicate. But today we're doing so much more with these children. Little Jonathan, 8 years old, and he's a severe spastic cerebral palsy. He literally has this pad now where he can point to it and he can talk to you and tell you what he needs. And that really has helped him and kept him calm. What about the child who is a mild cerebral palsy? Giving him something to move around, being able to get around. I mean, this kid looks happy. He's on a bike, he can move, you know, get from here to there. As I said, those children with those wheelchairs, electric wheelchairs, you know, they'll buzz all over the place. If they're cognitively aware to do that, why not? You know, these are things that we should do for these children. Now, cerebral palsy, we now do a lot of education, speech, occupational therapy. You know, we give them a goal. We, you know, said, well, let's do this goal. And then we work towards that. And then we will constantly increase the goals because we want them to be the best they possibly can. You know, and we want to, even if they have cerebral palsy, put them in groups with other children, you know, that are, quote, normal children. They need that socialization. Because of the spasticity, they need ankle braces, foot braces, sometimes surgery, those spastic things. Botulism, you know, it just makes those muscles, those nerves just relax, and those muscles relax because it's hard to be tight all the time. Their mouths, you need good mouth hygiene on them. And again, therapies. Prognosis is good. You know, these children, you know, many of them achieve to get up and to move around. We know that they're going to have some delays. And because of these delays also, they're going to be smaller, usually children. Most of the time, these children can live for quite a long time. They usually die due to complications like pneumonia. That's one of the biggest ones that I've seen. So these children require a lot of care. They require a family who gets this kid, you know, out of the wheelchair into the bed, you know, changing diapers, giving medications. Many of them don't eat normally and need a G tube, you know, gastrostomy tube and feedings and medications, getting them to places for their therapies. You know, it's a lot to care for them. So as nurses, making sure that they get everything they can possibly have to help them. Now, neurotube deficit. Neurotube is your spinal column, simply. And it's from head down to the butt. And if we look at these little blobs that are hanging out, that is the meninges and the spinal cord. So this is born on the outside. So if you think of those nerves, they're stretched, right? Many of these infants have no feeling in the lower extremities. They have some, but minimal. Some are able with braces to walk, but most end up with wheelchairs. You think of spina bifida, think of myelomeningocele. It's the same sort of outcome. It's just the outpatching of meninges in the spinal column. It is something that when they're, you know, intrautero, they do not close that spinal column when they should. It could be genetic, or it could be due to things with mom. obesity, diabetes, or they have a low B12, which is something they need to close that spinal column. So how are we going to maintain this? You have a child who's born who has this on the back. Well, the first priority is to put a dry, sterile dressing on it and to keep it as clean, sterile as possible. Now, they still have to urinate and stool, so they're kept on their bellies so that they're not compressing that in the back. The other thing is immediately, because most of these children are going to require a lot of either surgeries or are going to be needing Foley catheterization, straight calves every 4 hours because they don't feel their urine. We put them on latex allergy immediately because they're going to be exposed to it. So our priority with a neural tube, a myelomeningocele, is urinary function, making sure are they urinating. And if they're not, they're going to have straight caths every 4 hours. Another thing is because this is now the lower portion of the spinal column, which is stretched and those nerves are stretched, is bowel control. So urine and bowel, very important. Now, this child is perfectly beautiful, a gorgeous child usually, and their brains are perfect. They're just gonna have decreased function in their lower extremities. Manuel Louis was my little kid who the mother was crying over the warmer. And I could see, you know, why she was crying. And I said, "What's the matter, Mom?" And she goes, "Well, they don't know if he's gonna make it." I says, "Mom, your child is beautiful. They'll put that back in there." And I said, "You look like a mom who's going to take good care of your son. And you are going to have a beautiful boy, but you're going to have to help him, you know, with the lower extremities. We don't know how much function he has there yet." The next thing I did is I wrapped this kid up, made her sit down, and handed her her son. So now she could hold. So now look how beautiful he is. I said, "Just be careful of the back. Hold him like this." I stayed with her. 14 years later, she found me down in the emergency room, and this woman was pointing me through the window. So they came and got me, and I walked out, and she says, "Betty Boop," and that's what they called me. I said, "Yes." She goes, "This is Manuel Louis." I said, "You're kidding me." And he was in a wheelchair. He had just graduated from the 8th grade. He had gone to the 8th grade prom. He was in mainstream school. She had a keychain which had a picture of me holding Manuel Louis as an infant, which she had carried around in her purse. And she went looking for me to tell me thank you, that he was everything that she could ever want. So something like that, that little moment I took, can make a big difference in the child and into the parents. So how do we prevent these neural tubes? Is folic acid. You know, we've learned that in pharmacology. Should be taken before you want to get pregnant, but we know that doesn't always happen. There's other types of spinal muscular atrophy. Werding-Hoffmann is basically the floppy infant. They just have no muscle tone. And these children will die before 2 years of age. There's just nothing we can do for them. They just have no muscle tone. Duchenne muscular dystrophy. This is the diagnosis that your Hesse loves and your NCLEX loves. And Duchenne muscular hip dystrophy is a muscular disorder where the muscles are just, they're not working and they continue to get more and more atrophied. The muscles stop working. Ages 3 to 7 boys most of the time, and mom carries the link for this one. So this is a genetic thing. So it's progressive muscle wasting, weakness, and contractures. Now, what happens is usually in the late teenagers or in the teenage ages, you know, you're talking muscles not working. Remember, you have muscles to breathe, right? So and your heart's a muscle. So it usually ends up you die from respiratory or cardiac failure. Now, to diagnose this, they have a child who's falling, who's shuffling, not walking as good. You know, it's like going backwards. So you get a kid up who's walking and running, and all of a sudden he's falling and he's shuffling gait. They take him to the hospital and they do something called an EMG, an electromyogram. And what it does, it takes little muscles, your little nerves and muscles, they attach probes and they put electricity in it. And you watch the muscles be able to work. You could all of a sudden the finger will work or the arm will twitch. Now, one of the things about this test is once it's done, because we've worked some muscles differently, it can cause a little bit of discomfort. So be prepared to give this kid some sort of NSAID or Tylenol afterwards. So the clinical manifestations are that waddling gait, frequent falls, and Gower sign. You know, this is what I do. I get on the floor and then I walk up my legs to stand up because it's easier like that. Well, this is what these little kids do, which is not usual for these small children. And then you're going to start seeing muscles enlarging, the thighs and the upper arms. These children do have some mental impairment, and because the muscles don't work well, they're not as active, there are more tendencies to be obese. So there's really no treatment for it, but we're going to keep the kid active, physical therapy, braces as needed, and then of course genetic counseling if these parents want to have any other children. Guillain-Barré does happen in children, ages 4 to 10, you'll see it. And this is what we call an infectious polyneuritis. You'll see this usually after an upper respiratory infection. And you will see it start from the feet. You'll see the shuffling and maybe tingling of the feet and weakness, and it goes up. And when it goes up, we're worried about the nerves of the diaphragm. This one, our biggest concern is to make sure that the kid's breathing, because it's called ascending. From the feet, goes up. When it hits the phrenic nerve, then you can't breathe. These children, even adults who get it, will be required to be ventilated on a ventilator. And then all of a sudden, you will start seeing them breathe over the ventilator, and then it goes back down the way it started. Then afterwards, it's going to take quite a bit of time for rehab, physical therapy, occupational therapy. A lot of times these children, as we're going through the Guillain-Barré and the falling and the numbness, we're going to start seeing the urinary incontinence or constipation. Remember, you don't have nerves, you're just going to be urinate. You're going to be constipated because you can't push, you don't feel these things. Treatment for Guillain-Barré is IVIG, intravenous immunoglobulins, maybe steroids, and plasmapheresis, which is just cleaning their bloods up. Again, our biggest priority is respiratory support, making sure that we keep those lungs a moving. And the thing is, these children may not be able to move, but they're alert, they're awake, they understand. Many times they can blink yes and no. Tetanus is stepping on that nail and the rust, and it can cause lockjaw. And lockjaw basically means your neck gets rigid and it gets tight, and it tightens and it swells, and it can obstruct your airway. So what are we going to see with this child? So we'll see that stiffening here. We're going to see now the swallowing, and now we get the respiratory going. We need to give this child this tetanus vaccine. These children are sick. They can't breathe for themselves because of the amount of muscular tension, which really hurts. They'll be put on medications, really strong muscle relaxants. a lot of times we'll paralyze them with medications just to relax them as much as we possibly can. Many of these children will die. This is a very serious thing, tetanus. And it says if you have tetanus and you get to day 4, you usually will recover. But those first 3 days are pretty rough. So what do? We step on something outside and we have a wound, clean it with soap and water, as simple as that. I've had many children come in with things like bit by an animal. Again, remember, this is debris that's entering the finger, the hand, the foot, whatever. So we clean it all up and then we give tetanus immunoglobulins. And remember, we do give tetanus shots. Now, how frequent are tetanus shots? Every 10 years. So a girl born when she's going for her 11th, age 11, when she's going in for her checkups, going to get her tetanus booster. And they do tetanus and diphtheria at the same time now. They only used to do tetanus. Now they're doing both. Now, tetanus is something that if you have tetanus, they'll be giving you the tetanus immunoglobulins. We'll be doing good wound care again. And we also, again, muscle relaxants, sedatives, get this kid calm, and just kept monitoring that child. Botulism, we don't say botulism, that's been out for a long time. Well, I live in an area where there's a lot of people from other countries who live here, and there's many different cultural beliefs. And I've heard many times, you have an infant who's constipated, give them a little bit of honey or give them a little bit of Cairo syrup. Now, we don't know if that honey has been sanitized. We don't know how long it's been on the shelf or in your closet. And this can cause botulism, which is very dangerous. It starts out with weakness, dizziness, headaches, vomiting, and then it goes into respiratory paralysis. So it's all central nervous that we're going to start seeing on this. And then, of course, it's the lungs. So again, we have the IV botulism immunoglobulin. And as I said, it affects respiratory. We're going to support it again, paralyze, sedate, intubate, get this kid just to relax, and then give nutritional support, whether it's through TPN or through a continuous tube feeding of some sort. And we're going to keep, again, any kid immobilized, any of these 3 things I just talked about. We're going to be giving them physical therapy. We're going to keep them from preventing foot drops and using splints, et cetera, et cetera. Spinal cord injuries. I worked in the emergency room the last 10 years of my career, and it was a high-level level 4 trauma center. And I was the primary trauma nurse many a day. And you get a child come in who has, for instance, a 16-year-old sliding into third base. The kid's head hit the defender's knee and the whole stands heard a crack. When he got to me, he had a C5, C6. His spine was angulated, not like this, it was to the side. And he had some paralysis of his lower leg. My goal, priority goal, is keep that neck, immobilized and to prevent further injury on that child. It could be, again, motor vehicle, sports, pulling a baby out of the birth canal. You can hurt that neck and that spine, right? Falling and tripping. And then, of course, hyperflexion, hyperextension, like coup to coup, like in a motor vehicle, boom, boom, you can hurt the necks on those. So again, how do we want to take care of this child? At the scene, they'll put on this big stiff collar, they'll tape the kid to the board, and keep the kid as straight as possible. And that is your priority. It's not vital signs first, it's nothing else. If that spinal cord cracks, that poor child's going to be paralyzed, whether it's, 2 limbs or 4 limbs. So priority. And of course, after that, we'll be concerned of vital signs and, your respiratory, et cetera, et cetera. But our big thing is immobilization. So The progressive infantile spinal muscular atrophy, which is called the floppy infant, is which one? Did you remember? And that's pretty hard. That's your wording, Hoffman. But I'm telling you, it's Duchenne that they always look for. A lot of different things. Hope you heard just the concepts in there. So let's go ahead and start our cahoots. Who wants to win? You gonna win, Megan? Yep, okay. Ashley, you try. No, not today. LaShawn, you wanna win? Tiffany, that baby looks very comfortable. Good job.
She does. I don't want to move her. So I don't want
Don't
her
move.
to
Do
wake
not
up
move.
yet.
Don't move. Let a baby sleeping lay. Just listen along. All right, let's get going. Week 9. I'm still amazed. Week 9. A multi-select. What is the priority for a nurse to assess following a cast application? Absolutely everything. And you know something, if we could have pulses there, it should be there too. So if whoever put it there, you're absolutely right. I got to change it for the next group.
I was trying to.
What should the nurse
Onto the
monitor
Kahoot.
after a soft tissue injury?
Professor.
So remember, you've got this big ecchymotic area, and you really don't know how deep and how much it's occluding the blood flow. Always check neurovascular signs. Yes, Mackenzie, were you trying to say something?
Yeah, trying to log on, but I only got the first 3 digits of it, so I'll just watch you and listen to the rationales.
It is 1683438.
Thank you.
You're very welcome. Not a problem. And Tiff's up top. A fracture that penetrates the skin is called. Remember I told you this is the one that requires more assistance. If it penetrates the skin, you're going to be concerned about infection, and antibiotics are going to be required, and part of your assessment is going to be meaning to look for signs of infection. And it is called compound or open. It's the same thing. And Carly's up top. What is priority nursing care for a child who fell off the 2nd floor balcony? And I've seen this before. Again, making sure that spine is there. You can prevent things. You know, that boy who had that angulated C5, C6 fracture, I had to do an MRI, get him off the stretcher, off the board, onto the MRI table to do an MRI. And I didn't let anybody call the shots but me, was my kid. And the end of the story, he got feeling back in his legs, went to rehab, and he had a complete recovery. So it was a good story, the end of it. And it was the nurse who did it. Principles of managing soft tissue injury include Oh, just think of rice. Very good. Absolutely. You do that with a hemophiliac child who's got bleeding into a joint too, right? Same thing. Epiphyseal plate fractures in children may what? So epiphyseal plate fractures have to do with the bone growth, and we don't want to have a crooked leg or a shorter leg. So that is the growth fracture. The skeletal growth is most rapid during when? So when you're small, quick, remember pre-adolescent growth, a growth spurt. So it's both of those areas again. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? Skeletal traction, it could be a Thomas splint for a fractured femur. We don't use them as much anymore. It's the bucks and go to surgery. Those children used to be in bed for 30 days with a pin through their knee. Now, any neurovascular impairment is no pulse. Depending on whatever it is, it's an absent peripheral pulse. Very good. How should the nurse care for the skeletal traction for a child with a fractured femur? So you've got this traction on, it's holding the bone straight so that there's those little sharp jagged edges aren't, causing any pain, no muscle spasms, and you keep those weights hanging, no obstructions, never remove it, and document it once a shift. Excellent, good job. Priority action for a patient in skeletal traction with pins in place to minimize risk of infection. So we're going to do skincare, okay? Priority action, which means we're going to do something. Yeah, we're going to inspect it for sure, but the action is to do skincare, however the physician says to do it. Usually it's clean it, soap and water, and then a little bit of antibiotic ointment. When caring for a 9-year-old buck's traction, what action by the nurse is correct? So we're just going to check the capillary refill. That's all we're going to do. We've already said we're going to keep those weights hanging. Very good. A multi-select. Which assessment indicates an infant has developmental dysplasia of the hip? So this child's going to have those crooked leg folds. One's going to be higher or gluteal folds, and the positive Ortolani sign. And you guys did it perfect. A baby with developmental hip dysplasia would have which of the following findings? And asymmetrical leg folds. When you talk about the feet in and out, abduction, adduction, that's only older people with hip fractures, okay? Has nothing to do with the children. Infants will have those leg folds crooked and a shorter leg. And I'll hear all those clickings going on. Which statement by parents indicates more teaching regarding their 2-year-old infant with club foot? If you got a child with club foot and you're in the treatment, which one is you need more teaching? So you got to start it right away. They're going to have follow-up till they're old to make sure that we keep those feet and those legs the way they should. Every week they're doing casting. So bring it once a month. That's way too long. You know, these infants, they heal so quickly and they're so soft and tender. You start it right away and we can, you know, get these castings done in a month or two. A multi-select. Osteogenesis imperfecta. And you can see how important it is by this picture that we tried to keep the body in a position where we can get them up and get them out of bed and so they can come out and see the world. It'd be hard just to be sitting in a bed. But it is an autosomal disease and it is brittle bone that happens with these children. And there's no cure. We can just, you know, maintain it. When can osteogenesis imperfecta be most life-threatening? You know, do we really know the infant is going to be an osteogenesis imperfecta? Not all the time. So if you can imagine they're coming out the birth canal, you're pulling the head and twisting, you could be cracking bones, you know, and the squeezing of the bones coming out. I mean, how many fractured clavicles have you heard of infants coming out? It's one of the common things that can happen to an infant. So right there, right before birth, during birth process is the most dangerous. What is the pathologic cause of leg calf perth disease? And if you look at that right hip, do you see that fuzz going on there? That is showing you what's going on in an X-ray. And it's ischemic aseptic necrosis. There's no infection there. And what is the treatment? Bed rest, NSAIDs, and maybe some traction for it. And usually it will just, in time, will just go away. It resolves. Kyphosis, what is it? Kyphosis is the humpback. Very good. That's your thoracic spine. Lordosis is described as and I think the picture of that little girl really shows you what can happen. It's that lumbar spine just curves inwards. Looks like you're almost always going for a back bend. And scoliosis. When you think scoliosis, always think that S shape that's going on. And remember, over 40% is usually surgical treatment, a brace, and exercise, physical therapy. Adolescents with scoliosis have a 25% of the curvature of the spine would need what? 25%. What's the treatment? And that's putting the brace on and wearing it 23 hours a day. Remember, it's not till after 40% and usually a little bit higher before they'll go to surgery. We'll really try to do the brace and physical therapy. What is osteomyelitis? It's an infection, an inflammation of a bone, and it's going to require a long course of IV antibiotics. Remember, it's a staph infection, so we're worried about watching kidney function on these children. Make sure they're urinating well, making sure they're getting all their lab levels done. Juvenile rheumatoid arthritis is a what? And it's an inflammation disorder of the synovial joints. It is autoimmune. The body's attacking the joints and swelling them up and causing a lot of pain. Goals for JIA include what? So our goal is to reduce that joint pain and swelling and let a kid be as much a kid as they need to be. Systemic lupus erythematosus is it's an autoimmune disease, very good. And it attacks the organs, right? A multi-select. What can help a child with lupus erythematosus prevent exasperations? So sunscreen, decrease exposure to sunlight, and then before any sort of procedure, prophylactic antibiotics and steroids will help prevent having a flare. What organs can lupus affect? And it's anything, all the organs, whichever one it decides it's going to pick on. What is cerebral palsy? So cerebral palsy has all to do with muscle coordination and your body movements. You know, spastic is probably the most common, you know, when you have all of that rigidity. Myelomeningocele. So it's that big blob at the bottom, the base of the spine, and it's the spinal cord and the meninges in there. And it's the nerves in there. And that stretching is what causes those paralysis and decreased sensation of the lower extremities. The other concern with myelomeningocele is now the spinal column, you know, has been, you know, there's something wrong with it. Is the flow going to continue, or are we going to become hydrocephalus? And this child might also require that ventricular peritoneal shunt for extra fluid to prevent that hydrocephalus. Infants with myelomeningocele demonstrate what? motor sensory impairments of the lower extremities. Some children have some motor, some sense, and some have absolutely nothing. This depends on how big the stretching was of that myelomeningocele. Due to the decreased motor and sensations of the lower extremities, what must the nurse monitor closely? It's one of your priority assessments in a child with myelomeningocele. And that's urinary retention. Also remember to monitor the bowels also, but urinary is number one. Many of these children for life are every 4 hours urinary catheterizations. That's why they're on latex precautions. A key feature of Duchenne muscular dystrophy is what? And it has to do, when you look at dystrophy, it's not working right, so muscles, so it's progressive muscle wastage, yes. And we diagnose it a lot with that EMG, which shows nerve conduction and shows, is that nerve and that muscle working correctly? One of the procedures that a child with possible Duchenne's may need to diagnose this condition is called a what? I actually had one of these tests done many years ago when I had a neck problem, and it hurt. You can feel, it's like your muscles tension, and you already have. I had a neck issue, and it would go to my neck if they did somewheres in my arm. So be prepared for that poor kid to get something, for pain. And these children have something before they go to it. It's called electromyography. They're not fun. How is Duchenne muscular dystrophy inherited? Oh, her nap is done. Here's your mommy. And it's an X-linked recessive pattern. It's mom, and if you're the mother and you have a child who's 3 who's, been diagnosed and you want more children, how would you tell her what to do? Is they're going to need genetic testing to see what are their chances for another child with Duchenne's. In caring for a patient with Guillain-Barré, the priority concern is what? Your nursing priority. I had a nursing supervisor I worked with who had ended up with Guillain-Barré and was admitted to the hospital where I worked, actually. And I watched it firsthand go from this shuffling, then go into complete paralysis on a ventilator, trached, and then watching it come back, and then her going off for, therapy. And she was wide awake and alert. She would talk to you with her eyes. And it's always airway, Guillain-Barré, airway. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? How does that weakness go? I already told you with Guillain-Barré, they start first with maybe falling, tripping, shuffling of the feet. Then it might get to be incontinent, of urine or stool. And then it goes up and then it hits the phrenic nerve and then it's airway. So it's called ascending. From the feet up, ascending. From the head down, descending. A multi-select. Treatment for Guillain-Barré include Of course, we're going to watch the respirations, number one, and the medication is just the IVIG. It is a viral condition. There's no antibiotics that are going to do anything for it. So it's respiratory and IVIG. What type of cerebral palsy causes hypertonicity and poor fine motor skills? Like my little Jonathan. And it's called spastic. You think of hypertonicity, think of spastic, okay? Those are key to this type of cerebral palsy, spastic, hypertonicity, and of course, there's very poor fine motor skills, even gross motor skills. What priority action should a nurse take to a patient with a suspected spinal cord injury? Immobilization of the spine, very good, absolutely. You should get a tetanus shot every how many years? And then if you have an incident where you've stepped on something, they're going to give you a booster. They take tetanus extremely seriously. Every 10 years. It used to be 5 years. Now it is 10 years. That's the recommended. With a booster if you need it. What is a symptom of tetanus? This is severe muscle tightening and spasming, which can go into the airway, requires tetanus toxoid to be given, paralysis, very, very sick child. That's why tetanus shots are so very important. Last question. Most common causes of spinal cord injuries are what? Excuse me. And it is accidents, motor vehicle, driving, sports. Yes. Let's see how we did. Number 3. TD. Good job, TD. 2. Ashley. Very good. And number 1. Dina. Good job, Dina. Number 4. Kirsten and Tiffany. Good job, guys. What I want you to do is to sign your attendance attestation so we don't forget. Does anybody have any questions that I can help them with? Remember, those projects are due. If you have not turned them in, make sure you get them in. 6% of your grade. If I send it back to you, tell you, you could change this, you have till Sunday to do it. I will let you if your project is already in, just so that you can get your best possible grade that you can. I will be doing my review tomorrow night. Of course, everything will be posted, my review and everybody's else. So next week will be our exam. Come, on our Zoom, on your phone, and then we'll have class afterwards, okay? It's going to be a short class.
Have you graded the dosage calculation yet?
Have I graded it yet?
Yeah.
No,
Can I stay
I've
behind
not had
because
a
I have
chance.
questions?
Okay, that's no problem. I have not graded it yet,
you.
Lisha.
Okay.
Okay,
I was just wondering how I did.
okay, I will check for you.
Okay, thank you.
I'll let you know.
Okay, thanks.
Oh, you're welcome.
Thank you.
See you, Kelly. See you, Ashley. Good job. See you, Tara. Good job.
Thank you.
Thank you.